Kia ora. Welcome to this session, and we're going to discuss when and how to go about differentiation of a wide complex tachycardia. Wide complex tachycardia can be associated with some worrying pathology and is to be a likely cause for low perfusion status. Now, if this is the case, rate control or cardioversion is going to be required. The type of treatment is determined in the first instance by the severity of the presentation. When it's a life-threatening presentation, electrical cardioversion is a recommended course of action for any wide complex tachycardia. So this is regardless of the origin of the rhythm, and the differentiation is a very secondary concern. In other words, if a 12 lead has not already been taken, cardioversion would still precede this if the wide complex tachycardia was accompanied by a loss of consciousness or the inability to obey a command. Where the symptoms are less severe, the cardioversion recommendations differ, and this depends on whether the rhythm is ventricular in origin or not. For example, first-line drug therapy is different if the rhythm is, say, a supraventricular tachycardia. So the remainder of this presentation will explore the clinical perspectives in decision-making and reinforce when to attempt the differentiation and a tool that paramedics can use in the heat of the moment to determine the likelihood of ventricular tachycardia. The focus is on a wide complex tachycardia without a discernible supraventricular focus. In other words, the focus of the tachycardia with a QRS duration greater than 0.12 milliseconds and lacking visible P waves that have a fixed relationship with the QRS. While a few rhythms might cause a wide complex tachycardia, the short list is either ventricular tachycardia or a supraventricular tachycardia that has been transmitted via a bundle branch block. Now we refer to these particular supraventricular tachycardias as ones with aberrancy, and the abbreviation is an SVTA. The more likely examples of this are an atrioventricular re-entry tachycardia or some other form of paroxysmal supraventricular tachycardia. Where these are present and there's an intraventricular conduction delay such as a bundle branch block, it can be difficult to ascertain whether the rhythm is ventricular or not. To keep some perspective on this, the first step is to put the ECG to one side and to consider the clinical presentation. So, if there's a change in mentation, if the vital signs are spiraling downwards, and especially if the patient's not in a position to obey a command, differentiation is not required. The immediate action is to organise and to deliver electrical cardioversion. Just repeating this is going to preclude obtaining a 12 lead or any other non-essential assessments. On the other hand, further differentiation is appropriate if the vital signs suggest that it's not a severe presentation. Now, the basis of such decision-making reflects the overtly higher percentage of wide complex tachycardias that are ventricular in origin. So this happens 80% of the time, and only 20% of these wide complex tachycardias will turn out to be SVTAs. This leads us to the assumption that the wide complex tachycardia will be VT until proven otherwise. The bottom line is that managing an SVTA as VT offers very little risk to the patient. While on the other hand, if you were to manage a ventricular tachycardia thinking it was SVTA, this can result in delays and ineffective or inappropriate treatment and is thought to offer greater risk. So the default position then is to treat them as VTs until proven otherwise. So just to reiterate that point, from a clinical perspective, with an unstable patient with a wide complex tachycardia, it is far safer to assume that the rhythm is VT and that cardioversion or the use of amiodarone are safe choices in the unlikely event that the rhythm is an SVTA. Following on from the previous slide, differentiation is appropriate for the hemodynamically stable patient with a wide complex tachycardia. Now, there are some clinical signs that favour ventricular tachycardia. So the older the patient, the more likely it is to be VT. If there is a medical history of ischemic heart disease, it's more likely the wide complex will be ventricular tachycardia. If it occurs during an AMI, it's likely to be ventricular tachycardia. And if the patient has a cardiac myopathy, again, it's more likely to be ventricular tachycardia. The clinical signs that favour ventricular tachycardia are the presence of Canon A waves. Now, these are an irregular jugular pulsation. It's caused by ventricular contractions occurring when the AV valves are open, and thus the irregularity of this, plus their presence, will indicate AV dissociation and a greater likelihood of VT. The second clinical thing we look for is the severity of symptoms. And while this is debatable in terms of what research has to say, the rule of thumb is that VT is more likely to be in the presence of severe pathology. And in conditions where the physiological reserve of the heart is less likely to be able to compensate for the rate-related reduction in ventricular preload. The ECG characteristics that favour VT are AV dissociation, fusion or capture beats, a QRS that's greater than 0.16 of a millisecond, an extreme axis deviation, a RR morphology in V1 where the left rabbit's ear is taller, and a Brugada or a Josephine sign. But before we go on, it's essential to acknowledge that no single tool provides 100% surety in this differentiation. Factors like unusual pacemaker sites, such as the fascicles, or the patient's already taking antiarrhythmic drugs, can confound these algorithms. The main take-home point is that all wide complex tachycardias are managed as VT by default, and differentiation is only used in the hemodynamically stable patient. This is because VT has a better benefit to harm ratio by avoiding delayed or inappropriate treatment. Firstly, let's look at AV dissociation. So this is evidenced by P waves that are occurring at a different rate to the QRS complexes, and is taken as evidence that the ventricles and the atria are beating independently, as can happen with VT. In this example, we can see what appears to be a P wave randomly appearing in the middle of the wide complex tachycardia. In fact, there are a couple of other changes in morphology within the strip that could well be P waves buried into the QRS complexes. And when I measure the gap between these and then go ahead and make comparisons with the rest of the ECG, we can see that the P waves are regularly punctuating the rhythm but have no relationship whatsoever to the origin of the QRS. This we would call AV dissociation. Another feature was capture and fusion beats. Now these are also signs of a type of atrioventricular dissociation, and hence their presence during a wide complex tachycardia is a reliable indicator that the underlying rhythm will be ventricular. While differentiating the nature between these two types of beats will make no significant difference regarding the differentiation of the wide complex tachycardia, we're just going to cover the definition for both of them anyway. During VT, capture beats occur when the occasional sinoatrial node impulse is conducted through the ventricle. The evidence of this is a P wave that precedes a QRS complex that displays supraventricular characteristics. In other words, it's most likely to have a duration of less than 0.12 of a second. On the other hand, fusion beats occur when the ventricular depolarization have both supraventricular and ventricular origins, or in other words, the QRS becomes a combination of a supraventricular beat that has occurred at the same time as the abnormal ventricular depolarization. Fusion beats also have an altered QRS morphology to that of the underlying rhythm, but don't display any preceding atrial activity. In general terms, a QRS wider than 0.1 of a second is indicative of VT. It's unlikely that an ectopic focus causing VT will activate the ventricles via the bundle branches. The depolarization sequence uses the bundle of His and the bundle branches, and this is significantly faster until it exits the Purkinje system. This is reflected by a narrow initial phase of the QRS. This phase is called the ventricular activation time and is measured from the initial deflection of the R wave to the nadir or most negative point of the S wave. So this brings us to the Brugada sign. And an ECG is said to have a Brugada sign and is more likely to be VT if the ventricular activation time exceeds 0.1 of a second. Because VT does not activate the ventricle by the bundles, the initial part of the depolarization sequence is via the slower myocyte to myocyte method. It's this that results in a longer ventricular activation time, and this is a more reliable indicator of the likelihood of VT. But we'll be revisiting this particular aspect when we look at the Basel criteria. There are two further QRS morphologies that have a strong association with ventricular tachycardia. The first is a very specific RR morphology of the QRS in V1. This is the one that's commonly referred to as a rabbit's ear, where the initial R wave is the taller of the two R waves. A wide complex tachycardia is more likely to have a ventricular focus. The other sign that's more specific to VT is the slurring downward leg of the S wave in V1 or V2, and this is the one that is known as Josephine sign. This brings us to the Basel criteria. When there's no clear indication of the origin of a wide complex tachycardia, algorithms can help to distinguish whether it's a VT or an SVTA. In this section, we're just going to talk specifically to the Basel criteria. The Basel criteria were validated by Swiss and American universities in 2022. So what they found was sensitivity, or the likelihood that a person has the condition when the sign is present, and specificity, which is the likelihood of the condition being absent when the test is negative, and the overall diagnostic accuracy sat around 80% and was comparable or better than other algorithms. Of equal importance, the mean time to diagnosis was 39 seconds. Now, when they compared this to the Brugada, the Basel algorithm is more straightforward to recall and to apply. The Basel criteria are the presence of structural heart disease and widening of the early part of the QRS and leads to and AVR. So let's break these down and have a look at it more closely. The statistical likelihood of a wide complex tachycardia being ventricular tachycardia in the setting of structural heart disease is high. Now, there's a certain logic to this. Most structural heart disease is going to predominantly affect the ventricles, which of course are by far the greater mass of the heart. So acute myocardial infarction is a good example of this. Most occlusions resulting in an infarction cause scarring and some remodeling of the cardiac tissue in the affected area. This remodeling becomes electrophysiologically unstable. There is oxidative or metabolic stress. An example of these stresses would be a subsequent ischemic event, or in other words, maybe angina or something else that fits on the acute coronary syndrome spectrum. The same can be said for congestive heart diseases. These are characterized by remodeling and fibrosis, which are also arrhythmogenic. The severity of heart failure can be measured by the degree of decrease in left ventricular ejection fraction. And as this decreases, oxidative and metabolic stress increases, and thus the remodeled tissue is more likely to produce an ectopic focus for a ventricular tachycardia. The Basel study found a strong correlation between an ejection fraction of less than 35% and an increased likelihood of VT. As a rule of thumb, paramedics should consider symptomatic heart failure or a recorded New York Heart Association classification of evidence of this criteria having been met. So the last of the clinical features would be a patient who has an implantable cardiac defibrillator, and of course this has an acknowledged risk of life-threatening ventricular arrhythmias. The other evidence we're looking for is for rate-controlled therapy. which essentially is a clever pacemaker-like device which overpaces and takes control of a tachycardia before reducing the rate to resolve it. Little more needs to be said about this. Paramedics would automatically acknowledge that anyone with an implanted device to resolve a tachycardia has met the clinical criteria for a wide complex tachycardia to be most likely ventricular in origin. This brings us to the ECG characteristics using the Basel criteria. The characteristic is the time to first peak characteristic. This is the duration from the first deviation on the QRS complex to the peak of the first wave, regardless of whether this is an S wave or an R wave. The assumption is that a ventricular rhythm is not activated by the bundle branches. If it was, the initial phase of the QRS will reflect the speed at which the superconduction highway of the common bundle and bundle branches will distribute the wavefront to the Purkinje system. When VT occurs, it is more likely that the initial depolarization does not engage the common bundle. Instead, we have that slow cell-to-cell depolarization, and the evidence of this is that the initial deflection of the QRS, that is time taken to form the first peak, will be greater than 40 milliseconds. In the example shown here, we can look at lead AVR and see that the measurement starting from the initial deflection of the QRS to the peak of the R wave is greater than 40 milliseconds. This would be considered positive in terms of the Basel criteria. When I compare it with the one in lead 2, which is just on 40 milliseconds and maybe a little bit over, it's not as obvious. But remember, we're only going to need 2 of the 3 criteria overall for this to be a positive finding within the Basel criteria. If 2 or more of the criteria have been met, then the Basel criteria for determining that the rhythm is likely to be VT has also been met. Should only 1 or none of the criteria be met, it is far more likely that the wide complex tachycardia is supraventricular in origin, but has some aberrant conduction. In other words, it's an SVTA. So, let's recap what we've covered. A wide complex tachycardia without an obvious supraventricular focus can be differentiated into a ventricular tachycardia or a supraventricular tachycardia with aberrant conduction. The statistical probability is that the wide complex tachycardia will be ventricular in origin, but that 20% may be an SVTA. A delayed diagnosis of ventricular tachycardia or mistaking ventricular tachycardia for an SVTA is potentially more harmful than seeing an SVTA and misdiagnosing it as ventricular tachycardia. Most algorithms used to differentiate wide complex tachycardia acknowledge this fact, and the basic approach is to look for confirming evidence of the ventricular origins before looking for the alternatives. No one algorithm has been shown to be universally correct. However, the Basel algorithm has equally high sensitivity, specificity, and diagnostic accuracy when compared with other algorithms. It has the added advantage of being a little easier to remember and having a significantly lower time to get to the interpretation. The Basel criteria requires 2 or more of the following to be true. 1. The presence of a structural heart disease, such as a previous AMI, symptomatic heart failure, or the implementation of an ICD or RCT. Secondly, a duration of greater than 40 milliseconds from the QRS activation to the peak of the first wave in lead 2. And finally, and thirdly, a duration of greater than 40 milliseconds from QRS activation to the peak of the first wave in lead AVR. I hope this information has been useful. If you have any questions, feel free to contact somebody on the team. But in the meantime, noho ora mai.